I'll record the session tonight. We're glad to have you join us. Hope you have a good day ahead of you on Friday of the week. Pleased to be able to share these cases with you. And the first two cases we're going to discuss are from Dr. Lin. And I will share the slide that she has shared with me. And then we can talk about the cases together as we look at the slide. So we'll start with a gastric biopsy that you had, Dr. Lin. Would you like to tell the story of this case? You need to unmute.
The person, a female with 7 years old. Yeah. And she had a ulcer in outer anatomy.
So we look at this fragments of tissue, and it's
Yes.
Obviously doesn't have any oxyntic mucosa. It has antral type glands. And we can see there's a lot of loose stroma with some benign serous glands here. And then we have this superficial tissue that shows more of the epithelium is more foveolar or gastric lining type of surface epithelium. We have basal nuclei, and we have a lot of cytoplasm. It kind of looks a little bit distorted. The architecture is disrupted. But I think there's the sense that this is part of maybe a polyp. We see the pinch mark here and maybe here from the biopsy process. And that happens quite a bit with gastric biopsies, that you'll get some pinching and so forth. The foveolar epithelium, I don't think is neoplastic. It doesn't look dysplastic. The nuclei are basal. So I think that this fits in the category of a hyperplastic polyp. We have a little bit of vascular proliferation here, which might indicate that there's sort of an inflammatory stromal proliferation associated with this. Sometimes the inflammatory polyps can have a very pronounced foveolar surface hyperplastic element as well. So the boundary between hyperplastic polyp and a inflammatory polyp is a little bit distorted. Typically with the inflammatory polyps, we lose any evidence of a muscularis mucosa. And that also can happen with the hyperplastic polyps. The muscularis mucosa becomes less attenuated or stretched out, and we don't see very much of that. So the only smooth muscle that I see here are just these few strands here that are more vertical strands rather than a horizontal strand. So I think we're still above the muscularis mucosa with this polyp. And we have this sort of reactive change in the smooth muscle that is drawing the tissue upward. So my diagnosis for this would be a benign gastric polyp, probably a hyperplastic polyp without any dysplasia, without any risk of malignancy, and would be consistent with a post-inflammatory, post-ulcer type of change associated with the the, uh, the, uh, healing process. Sometimes in these polyps, you will see epithelial atypia with loss of cytoplasmic mucin and a little bit more atypical appearance. But in my experience, those do not prove to be pre-malignant. So I've looked at cases that were kind of borderline like that and tried to do special stains like P53 or some other malignant marker, but that has not proved very helpful. So I don't think there's any particular immunostain that helps you in the decision between benign and malignant here with this type of a lesion. Any questions or comments anyone has about that case?
Yeah, as you said, in hyperplasia hyperplasia polyp, we will need to see inflammatory cell in the stromal without them.
Yeah, so the hyperplastic polyps usually do not have much inflammation, but many times an inflammatory polyp can also have just very delicate vessels, kind of like these here in this part of the biopsy, that look a little bit like granulation tissue and not very much inflammation too. But usually there's more inflammation in the inflammatory polyp.
Yes.
Well, if that's the case, let's go on and do case number 2 that you have, Dr. Lin.
Lưu Việt Thầy đang hỏi em là mẫu số mấy.
Không mời được. In history, a 65 years old female has a tumor in her nose cavity. And in this biopsy of this tumor. And I have stained a lot of marker because I look like it's very brain tumor, maybe benign, with hemangioma. I think so. The first I think is hemangioma.
Yeah, it has a vascularity. Yeah, I see that here. Some delicate vessels, sort of endothelial hyperplasia.
No. Yes.
And the tumor cells here are quite uniform.
Yes, uniform.
I don't have a higher magnification, but there's a moderate amount of clear cytoplasm and fairly uniform nuclei. It looks as though they're atypical and would be considered malignant based on the pattern of cells. Usually a vascular tumor, especially in the sinonasal area, I mean, those are usually younger patients. Angiofibroma is a very young person's type of diagnosis and usually males. So this lesion has the appearance of a potentially high-grade tumor because it's quite undifferentiated. And so the differential considerations in a sort of a tumor like this would be, sinonasal undifferentiated carcinoma, a poorly differentiated squamous cell carcinoma, an EBV-related carcinoma, Epstein-Barr-related carcinoma. And then there are a couple of things that might present if we were thinking of this is just a biopsy and there might be other morphologies. So sometimes there's a sinonasal carcinosarcoma or sarcomatoid lesion that can have different morphologies in different areas. So it's a more pleomorphic, polymorphous appearance with some very bad areas like this. And other times there'll be a more sarcomatous or different appearance. And there's, so the pterodocarcinoma is another tumor in the sinonasal tract that can have very high-grade areas like this with other heterogeneous elements as well in these tumors. And then we have the tumors that are related to loss of the SWI SNF functionalities, the SNF capabilities. Those are what we call the INI deficient or BRG1 deficient tumors that can present in this location and also have a very high grade and undifferentiated appearance. So what would be a good consideration of immunostains for this tumor? Well, certainly cytokeratins to verify that it's carcinoma, neuroendocrine markers to rule out neuroendocrine type of carcinomas. And then you want to do any of those markers that will identify the BRG, like INI1 or BRG1, preferably both, because it could be either one. And then also thinking about Epstein-Barr status, EBV-ish, if you can do that, or potentially HPV-related squamous carcinomas could occur in this location, though not quite as commonly in an older patient and in a high-grade tumor like this. So that's my impression, that this is a high-grade, probably carcinoma, and I would imagine that it's either going to be in the INI1 deficient or BRG1 deficient category, or potentially in the Epstein-Barr category. But I can't rule out some of those other lesions as well. Now, you did some immunostains, Dr. Lin, and I believe it was negative for neuroendocrine markers. Is that right?
Yes. Neuroendocrine marker is negative. Like thrombogeny A, thrombogeny A negative. CD56 negative.
Yeah, I think we've got some of those stains here you sent to me. But still a pretty high proliferation rate, which I think this probably takes it out of the undifferentiated carcinoma, the sinonasal undifferentiated carcinoma category, because this Ki-67 is only maybe 20 to 30% at the most. And sinonasal undifferentiated carcinoma would usually be much higher, probably 70 or more percent positive with Ki-67.
Yeah.
So this could be a conventional non-keratinizing squamous carcinoma, or one of those INI deficient ones. So this is kind of borderline to higher grade. It does have some squamous element here with the P40 differentiation being present.
Yes.
And what else did we have? And a little bit of CK56. Yeah. This is a little bit on the weak side, but as you see towards the edges, you're getting more staining. So this is, I think, a weak positive stain with CK56.
Yes.
Those distinctions between the INI deficient lesions and the squamous carcinoma, poorly differentiated squamous carcinomas, either HPV related or Epstein-Barr virus related, there is some important therapeutic differences with those. So the Epstein-Barr virus related tumors would be treated one way. HPV tumors might be treated a little differently, whereas the INI1 deficient tumors, a little different approach and less likely to be responsive. So that is a helpful distinction to be able to make and help to guide the treatment for those patients.
Yes, thank you. But in my pathology, EBV test doesn't work.
Yeah, I know sometimes it's difficult to access all of the stains that will make a difference in treatment. But sometimes if you can explain to the surgeon or to the patient the differential considerations and how that may change your diagnosis or the treatment, then they may be able to find the right place to get that testing done. Does anybody else have any questions or comments on these cases? These are challenging cases. I think this is an interesting way to approach these sessions that we do, and I would certainly say to any of the other participants that if you want us to consider cases or you want to present a case that you have, please work with Dr. Lin and we can arrange to present those cases in this conference next month or after that. Let me go to a couple of soft tissue tumors that I thought I would present for you. I have a couple of examples of some fatty tumors that I think will be worth discussing. I don't think we talked about fatty tumors last time, did we? So this is an example of a lipoblastoma, which is a benign fatty tumor that can occur in the subcutis or sometimes in deeper structures. And it has this characteristic appearance with lobulated structure and some associated more solid areas. And in these solid areas, we find the presence of some lipoblastic cells. Like here's one with a bubble indenting the nucleus here. We can look around and see some more examples here. Is another dual bubble Here's another case, another lipoblast over here. But there's really no atypia and very little in the way of myxoid change here, although this can appear slightly myxoid to some people. The tumor overall tends to be sharply demarcated, as you see here. We have a pretty sharp margin, so it's easily resected. It's not a challenge for the surgeon. And does have this distinctive appearance with the lipoblasts and then this variable fatty background. So this is lipoblastoma. I've got another example here I can show as well of this tumor, just to give you a little bit of a spectrum. Oh, I think this is the same section. Let's go on for one of the others here. So here's an example, again, fairly sharply circumscribed, lobulated, not as much solid tissue, but as we come into higher magnification, I think you'll see the fat cells are variable in size. And as we get into higher magnification, you can see that some of them have this lipoblastic appearance. Now, typically for a lipoblast, we like to define it as a cell which has more than one lipid droplet and some indentation or alteration to the nucleus with that fatty bubble. So sometimes you have to search a fair bit to find those cells. And of course, we can see them in a variety of both benign and malignant tumors. I think there may be some in here. Let's see if the next one has a few more here. Oh, that's not one. Well, let's see what we've got here. This is actually a pediatric patient. And in pediatric patients, you can have an even more immature appearing mesenchyme, as you see here, this sort of organoid mesenchymal tissue. But in some of these areas here, I think you can begin to see some lipoblastic features to some of the cells. So in a pediatric or neonatal setting, one of these tumors can appear even more cellular and atypical, but can still have the same benign outcome in these patients. And then I think there's one more example, if I'm correct. Yeah, one more example here. This is a very pale slide, I apologize. So this case has a little bit more myxoid appearing background, but again, very bland. And oops, there's the lipoblast right there. So here we see this dual vacuole and a nucleus that's indented in between the two lipid droplets. That would classify. Here's another one. You can see here's the nucleus on sort of both sides of this lipid bubble. So that fits nicely with this appearance. And actually, these bi-droplet appearance lipoblasts are quite common in the lipoblastoma. So here's another one. See, very, very characteristic appearance of these lipoblasts. So any questions about lipoblastoma? Okay, we've got another lesion here.
I have a question. I think lipoblast cell has a nucleus in the center of cell.
Yes, the lipo. Whoops, this is not what I was going to do here. The lipoblasts, they have. Well, let me actually. Maybe I can pull the whiteboard up here. Well, I'll go back down here to that case here. So the lipoblastoma has a, let's see, I want to draw, where's my draw tool? Okay, so the lipoblast will tend to have the nucleus. Well, let's say they have a nucleus here that has indentations. Because it has lipid droplets that are surrounding it and pushing in on the nucleus here. So this is the nucleus here. And then it's got these lipid droplets as part of the outer portion of the cell that are indenting or altering the shape of the nucleus. With lipoblastoma here, as I've indicated, many of these will be cells like here, where it's a two droplet, and you may or may not see the nucleus in between. But oftentimes the nucleus will be in this area between the two lipid droplets.
Yes, thank you.
Okay.
The picture.
Yeah, I'm not a very good artist with my computer here, but anyway, all right. So we got through the lipoblastoma. Let's go back here and look at one of the other fatty lesions that I've been learning about here. Well, let's talk about the fatty malignancies, and because they can also have lipoblasts and some do not. So the classic, most frequently encountered tumor is the well-differentiated liposarcoma, which typically has fat, but it doesn't necessarily have lipoblasts. It doesn't have these cells we've been talking about, but it may instead just have these atypical cells in the stroma, in the fibrous stroma. So you see here some bizarre cells here, over here, and they're in the fibrous background tissue. And that goes for a challenge to recognize those cells and to find them. But the place to look is usually in the fibrous tissue. The other thing, of course, is that with well-differentiated liposarcoma, this is usually a tumor of the retroperitoneum, or maybe the scrotum, and its more benign variant occurs in the proximal thigh as a or atypical lipomatous tumor. We don't even call it sarcoma. But one of the challenges is when you get a tumor like this, which is from the retroperitoneum. And as we look at this tumor, we notice that it has a lot of myxoid change to it. And so we see all of this myxoid tissue here, very loose myxoid type tissue, and it's in a sort of fatty location. And there can be the temptation to consider this as a myxoid liposarcoma. So that is a potential pitfall when you find a retroperitoneal tumor that has fat and myxoid changes. It's not going to be a myxoid liposarcoma. Rather, it's much more likely to be a well-differentiated liposarcoma. And in this case, the atypia in the stromal cells is relatively mild. You see here, there's just a little bit of stellate cell change, a little bit of nuclear enlargement, and not a lot of high-grade atypia. So you kind of have really a very well-differentiated tumor where you're kind of wondering, is this just a myxoid lipoma, or is this myxoid liposarcoma, or is this a well-differentiated liposarcoma? In the retroperitoneum, you can immediately eliminate the myxoid liposarcoma. It just does not occur in that location. And anything that has any degree of atypia associated with a fatty tumor with these expanded stromal areas, even if it has myxoid change, is most likely to be a well-differentiated liposarcoma. And how do we know that? Well, that's based on the finding of the characteristic molecular changes, which sometimes have some immunohistochemical correlates. So for the well-differentiated liposarcoma, there are a couple of immunostains that can be useful. So for example, here is one immunostain that can be quite useful in this situation. And that is P16. So here you see the P16 positive control in the cervical tissue here, cervical squamous or glandular carcinoma. And here is this myxoid retroperitoneal lesion with, as we look down here, we see a lot of nuclear positivity in almost all of these cells. So you shouldn't see that in a myxoid liposarcoma or in a myxoid lipoma. That should not be seen. So this is pretty strong evidence that this is going to be a well-differentiated liposarcoma with myxoid changes. There are two other stains that can be useful. CDK4 is also an uncommonly activated gene in well-differentiated liposarcoma and will stain positively. Now, not every laboratory has CDK4, but most of your laboratories will have P16 because we use it in so many other entities. Additionally, the true marker, the genetic hallmark, is the presence of an MDM2 mutation, which will usually be manifest as a positive immunohistochemistry for MDM2 protein. That's not as sensitive as the FISH testing for MDM2 rearrangement or amplification, which we would prefer. But if you don't have access to that, the MDM2 immunohistochemistry can be used, and if positive, is a pretty good substitute for that finding. Now, the other The other situation where MDM2 can be useful is in well-differentiated osteosarcomas, intraosseous osteosarcomas, and a few other settings as well. So it's not a single diagnosis stain, but it is very useful. Additionally, when you encounter the high-grade retroperitoneal tumor or dedifferentiated liposarcoma, that can have a variety of appearances, a variety of morphologies, usually with very little or no fat. That will also be positive with MDM2. And so when you see a retroperitoneal tumor that looks like a high-grade undifferentiated sarcoma, then we would also be thinking about a dedifferentiated liposarcoma. And the MDM2 status would be very helpful in confirming that. So dedifferentiated liposarcoma typically presents in a patient who has an associated well-differentiated liposarcoma. And so there may be some areas that are dedifferentiated and other areas that are still well-differentiated. So sampling is important. That's true in the biopsy or in the resection, as well as the fact that many patients can have areas of low-grade dedifferentiation. And that would be when you had more tissue that looked, say, like this, our initial slide, where we had a much more solid fibrous tissue with a little bit of atypia, and maybe you have some heterologous elements like smooth muscle, or maybe a little bit of cartilage or something like that in this tumor. That can be a manifestation of dedifferentiation, but with a low-grade dedifferentiated component. So the dedifferentiated lipomatous tumors in the retroperitoneum can be a little bit heterogeneous because of that low-grade, high-grade contrast, and the occasional presence of heterologous differentiation, which can include things like bone, which you see here, cartilage, smooth muscle, we've mentioned, and skeletal muscle, higher grade muscle as well. So all of those are seen in this tumor occasionally. And if you look at enough cases over your career, you'll probably see most of those dedifferentiation patterns. But the most common one is that you get a high-grade undifferentiated type sarcoma that is present in the retroperitoneum, and you have an associated area of well-differentiated tumor. So any questions about undifferentiated or dedifferentiated liposarcoma or well-differentiated liposarcoma that we've talked about?
I have a question.
Yes.
Hello, Professor. Can you hear me?
Yes, I can hear you.
Thank you very much for your yeah. So you said to present two kinds of sarcoma. So could you help me to show that what is the most typical characteristic to distinguish liposarcoma and lipoblastoma?
Yeah, so the key difference is the atypical stromal cells between the location of the atypical stromal cells between lipoblastoma and well-differentiated liposarcoma. Those might be things you would consider in the differential. but also location. So lipoblastoma can be present in the trunk or the body wall, maybe the extremities. Well-differentiated liposarcoma is typically retroperitoneal or scrotal. The atypical lipomatous tumor, which looks the same, is usually a deep location, intramuscular or deep to the fascia, rather than superficial where lipoblastoma would usually occur. So that location is a key factor. And then the atypia of the cells,
Yeah,
finding
I
the
see. Thank you very much.
atypical cells in the fibrous tissue would help to differentiate lipoblastoma where you have no atypia from the well-differentiated liposarcoma where you should have those occasional atypical cells that are present. And then with undifferentiated or dedifferentiated liposarcoma, it looks like a very high-grade sarcoma, which is very different from those other tumors usually. Now, the low-grade dedifferentiation will still have some significant atypia like you have in well-differentiated liposarcoma without dedifferentiation, but it will just have more solid tissue and usually maybe some heterologous element as well. So let's contrast this and look at myxoid liposarcoma as well, because that, I think, is an important consideration. Myxoid liposarcoma is also the same tumor as what was previously called round cell sarcoma. And the reason these are the same tumor is because these two tumors or these two morphologies share the same gene fusion or the same translocation. So this is this 1216 Q13 P11 fusion gene, which is a fusion between DDIT3 and the FUS gene, the FUS gene. Now, not every fish lab will have this marker, but most fish labs will have a FUS gene marker because that's a fusion gene partner for Ewing's or several other tumors as well. And so if people are doing fish testing for gene fusion products, they should have some marker that includes this partner. And you can detect that in those laboratories. Now, the other thing about this tumor is that the degree of atypia tends to be quite low. It's not a high-grade pleomorphic sarcoma like dedifferentiated liposarcoma. And that's a key principle that we have come to recognize, and that is that many of these tumors that have a single gene translocation and fusion, they tend to be very monotonous, very uniform tumors. So Ewing sarcoma is not a high-grade pleomorphic tumor. It's just very uniform type of tumor. Synovial sarcoma, very uniform tumor with low-grade atypia. And so myxoid or round cell liposarcoma is like that in that it has a fusion gene partner that gives you this appearance. And now look at, here's the example of one of these tumors. We don't see much fatty differentiation here. In fact, we just see a myxoid proliferation with these spindle cells or stellate cells, and maybe this is a fat cell. We can't be totally sure, but there are a few vacuolated cells that might be fatty related. Maybe this is a lipoblast here. Maybe this is a lipoblast here. But they're not very prominent, and it's not a predominantly fatty tumor. So in a biopsy like this, seeing multiple morphologies and patterns, we might have difficulty in remembering to include myxoid liposarcoma in our differential diagnosis. Here it looks as though we have a lot of delicate vessels, and that's a key because many fatty tumors will have this delicate vascular pattern. That's true of some of the myxoid tumors as well. But that's maybe a clue, along with these occasional cleared out cells that look possibly like they're lipocytes or lipoblasts, as you see here. For a tumor like this, myxoid tumor with relatively low-grade cytology, I think the differential includes myxoid liposarcoma. It also includes myxoid chondrosarcoma. And I suppose there might be some other myxoid lesions that might have some things like this, but those are the two main entities that I would consider as far as malignancies that could have this appearance. And of course, they have different molecular markers. So the myxoid chondrosarcoma will not have the DDIT3 FUS fusion gene. It has a different fusion gene in that tumor. And I'm trying to remember what it is, and I can't remember right off the top of my head. I usually have to go look them up. And I would use a source like pathology outlines or something like that to remind myself of where the fusion gene partner is for that tumor. And if you haven't used pathology outlines, I would certainly recommend it. Here is an example page from Pathology Outlines, just to show you what it looks like, and the type of information that you can have here. So this is Pathology Outlines, a topic page, which in this case is hemangiomas and variants, so benign vascular tumors. And you can see that it has a lot of hyperlinks to differential diagnostic considerations. It has links to articles that may tell you about the epidemiology or about the sites where it occurs and so forth. And then it will also usually have clinical radiographic images, gross photos, and ideally some microscopic images and some virtual slides. So you get a whole rich array of information from Pathology Outlines that can help you in the remembering the differential considerations, as well as staining results and molecular cytogenetic issues that may be pertinent to that tumor. So for me, this is like, oh, I don't have to remember these things. I know where to find the information very quickly. And of course, the advantage to this is that it's all open access, freely available on the World Wide Web to anybody, whether you're in Vietnam or whether you're in Kuala Lumpur or whether you're in New York City. So I like this site. I will admit that I am an associate editor for one of the topic areas, and I've written for the pages, but I find it very useful resource for cases like this where I can't remember something, a little detail, or I want to know what the stainings look like for a particular tumor. Well, we've managed to talk our way to 9 o'clock, and I don't want to run into your workday too much. So I'll stop here and let you ask any additional questions you have. If you have suggestions for topics we should cover next month, please let me know, and or Dr. Lin, let Dr. Lin know. And also you can, of course, always email me cases or consult issues that you want to ask about.
Yes.
Yeah, thank you very much.
Thank you so much.
Okay, I'll send you the link to our recording as soon as we've got it posted.
Yes.